Welcome, everybody. Delighted to see this fabulous turnout. And I'm really delighted to be able to introduce Professor Carl May from the London School of Hygiene and Tropical Medicine, who's Professor of Health System Implementation and is really a giant of implementation research, who I'm going to age us both, since I've known him for over 30 years now. But he's really developer of normalization process theory, of burden of treatment theory, and all things implementation. I'm sure he's going to be delighted to answer lots of questions at the end of what I know will be a barnstorm. So I'm going to hand over without further ado. No pressure there, Carl.
Francis. Very much. So, it's a fact universally acknowledged that something. Get close to the mic. Universally acknowledged that if you have a sociologist interested in technology, some actual technology, they will either break it or on one occasion, I most unfortunately poured water into an overhead projector. And water plus electricity means fire. And so there was a lot of smoke and fire engines and things like this, and I never gave my talk. So this isn't working.
Try clicking on the actual screen once with your mouse and then use the clicker. That's it. Click once on there and then try.
Well, at least we've got a title to it. So, as Francis has told you, I'm Carl May. I'm a sociologist and implementation researcher. And I'm going to talk today really about some of the work that I've been doing since I last gave the Maurice Bloch lecture in 2013. And Audrey actually remembered me. So either something terrible happened that I've filled it out in my mind, or I was, I don't know. So anyway, look. What I'm going to be doing, I'm going to be talking, one of the things you should never do is look into a laser pointer to see if it's working. Anyway, I'm going to be talking about 4 things, because I'm very interested in how inequities in healthcare are actually implemented. They're designed into healthcare services and then implemented. And I came to this because I was working with 2 American colleagues, Elvin Gang and Corey V. Bradley. Corey V. Bradley is the most charismatic man in the world. About how to integrate critical race theory with the ways in which we conceptualize implementation processes. This was fascinating and continuing process, and a paper has come out of it that proposes a patient-centered equity design approach to complex healthcare interventions and innovations in service provision. It would be so wonderful if that paper had actually been published, and I could put the title and everything on screen. But the joy of Springer Nature / B&C publications means that although I did the proofs many weeks ago and we paid the invoice many weeks ago, it still hasn't come out. So I'm broken-hearted, obviously, about that, and perhaps even psychologically damaged or triggered in some way that I can seek damages from that company. So this is my starting point. Inequities are implemented, and they are made real by services. Now, I'm not suggesting that people in service provision sit around and say, how can we disadvantage the poor and frail, vulnerable, and different patient groups? That's the last thing that I think is true. But it is absolutely, but unless you're in Alabama, when things are very different, or Louisiana, or pretty much anywhere. But I mean, we'll just leave that alone for a moment. The health professionals and health administrators in practice desperately try to achieve equitable delivery of services. And somehow, this doesn't always come about. I am using a WHO definition of inequity because it helps me by saying inequity is the presence of unfair and avoidable or remediable differences in health among social groups. And we tend to think about social determinants of health as sort of natural phenomena, like gravity or the tides, or the orbit of the moon. There will always be social determinants of health, and they will always, in some way, represent different forms of disparities or inequities. I like to call social determinants of health politically modifiable determinants of health, because that's in fact what they are. It's important to say something about what implementation is. So implementation is a process that happens when one group of actors seeks to translate their strategic intentions in the everyday practices of others. And these processes are ubiquitous in organisations of all kinds. Everybody in this room has recently, I guess, been implemented in some way or another. I certainly have. And then, what can we say about that definition? Well, an important component of that definition is, in fact, that it represents the play of power. Powerless agencies tend not to be able to implement their strategic intentions. Powerful agencies tend to have much less trouble. I'm not suggesting that it's easy, but they have much less trouble, first of all, because their strategic intentions tend to be taken for granted by people who work for them. The REF is a great example. A set of strategic intentions lost in the midst of time, but are now part of everyday referred to as academics, and that conspire to generate powerful inequities and also a sense of misery and disconsolate feelings. So, how those resources get played out becomes really important in service design, intervention design. I come to this having conducted two very comprehensive qualitative evidence syntheses, where we were very interested in how inequity, illness trajectory, and burden of treatment interacted with each other. These were very I found myself a couple of years ago in the not enviable position of having to analyse and code 244 primary qualitative studies. I recommend that you don't do that. But it was important to me because it meant that I was able to develop a very simple hierarchical model of inequity, that some are societal, some are institutional, because they're the result of political and legislative programs. Some are systemic. Pretty much everybody now experiences fragmentation of care. And spends a lot more time carrying messages from one bit of the NHS to another. And also relational. And this is crucial, I think. I'm particularly interested in relational inequities because they are about what happens to our social capital and how different forms of social capital are depleted or reinforced by healthcare systems. A few years ago, I discovered that there was an American social scientist at the University of Utah, Megan Reynolds, who produced a really nice kind of theoretical model of how healthcare systems at a macro level generate inequity at a micro level. And Megan Reynolds' work on health power resources theory is really important. And of course, she characterizes this in terms of the health economy in the United States. But pretty much everything that she's got here also applies to us. So we have 4 different kinds of mechanisms that are enacted by healthcare providers and which generate inequity. Now, I can see some people are taking pictures of these overheads. There's no need to, because I'm going to put, Audrey has got them, and you can simply ask her for a complete set of overheads, and that's fine. A text of this lecture will appear on ResearchGate in the next week or so, so that those of you who want to admire my word processing skills will have an opportunity to do that. So we have these 4 mechanisms, healthcare systems and the societies that drive them stratify their populations. And they don't just stratify them according to quantitative variables, they also stratify them according to eligibility for care and moral value and social utility. And a really, really great example of this are the current debates in the United Kingdom about why so many people are on sick benefit because they have mental health problems. So there's a whole load of background stratification around the founding principle of the British welfare state, going back to, I think, 1830, when the ratepayers of the parish of Speen in Buckinghamshire developed the first British welfare intervention. The Speenham land system, which some of you may have heard of if you did O-level British social and economic history in the middle 19th. That's Audrey, and she's with us. She's really with us. She's appreciating everybody. So that's the only O level I got. So I remember everything in it with sort of horrible clarity. Some of you may know, one of the things that I've been really interested in for a long time now is how different kinds of behaviours and interventions, technologies, practices become normalised into practice. Tracy Finch and I and others have developed a really robust theoretical model of this process. I think it's inspired about 5,500 studies now, so I can retire. A really important thing is that the production of inequities is normalised. It's invisible until somebody does a study of social inequalities in health. It's lost in the individual lived experience of people who use healthcare systems or services, their families and their friends. And this is why I'm interested in social capital. I'm interested in relational aspects of qualities. And one of the things that drives this is a horrible word, which I've refused to use in this presentation, responsibilization. And it is the shift of personal moral responsibility from systems to individuals. And here is a little model of that process that looks at the work that patients and their families have to do to effectively participate in their care. This is a really crucial thing for pretty much everybody who works in community health and primary care. Large numbers of patients and families who struggle to effectively participate in care because a significant workload is driven to them. They have to be actively engaged, they have to be resourceful, they have to seek expertise, and of course they also have to be prudent in what they ask for. So they have to ration themselves, they have to be good patients, they have to be clever patients, and they have to be compliant patients. And we all know, anybody who's been in hospital will have watched somebody who isn't a compliant patient not getting their cup of tea in the morning. So systems have ways of gently punishing the non-compliant, the disengaged, the non-resourceful, and the imprudent. When I put this presentation together, it was full of pictures of Lenin and the Russian Revolution, because I felt I was kind of promoting some kind of radical Marxist view of healthcare. And I had a Ukrainian friend who suggested to me that the last thing that he would want to see is a picture of Lenin. And so I took them all out. And I couldn't find then a revolutionary hero who didn't have at least some genocidal intent. So there you go. And I used to use cartoons from the New Yorker to illustrate my talks. But in fact, what happened then was that I got a letter, a cease and desist letter from Condé Nast, the publisher of the New Yorker. I was putting all of these pictures online, and that offered me the choice of stopping doing that and taking all of those presentations down in some way, or spending some years in a small room with a member of the Aryan nation called Raoul. And since I wanted to avoid the federal pen, ever since then I've sort of just done really poorly put together diagrams. Let's think about what's happening next. So I've sort of outlined how inequity is expressed through the work that people have to do and their unequal capacity to do that work. I'm some experience of this as a hospital patient and an outpatient. And it is a completely normalised way of life once you're confronted with a set of patient-initiated follow-up portals and all of the stuff that comes in your direction from a hospital now, all of the texts, the demands for information, all of this stuff, very valuable, I suppose, to somebody, but it's never represented ever in any of the consultations that I have with doctors or nurses. So where that knowledge goes, who knows? The design of complex healthcare interventions, whether those are experimental or whether they're everyday innovations in service, is in a sense an equity issue. We can design inequity out of some interventions. It's not easy. It's complicated. And it's also slightly grey for reasons I can't at the moment whatever. So with my many colleagues who have worked together on a paper that I cannot show you because it's not yet published, thank you, BMC, we kind of enunciated 3 design principles that demand co-creational work. So equitable civility and dependability. Services that have unpredictable trajectories and outcomes cannot be equitable. If you're a patient and you don't know what's going to happen, that may mean that you don't know what to do. And if you don't know what to do, then you're stuck. Because sometimes nobody will tell you. And a great example of this, some work that I did with colleagues in Southampton some years ago now about treatment escalation planning at end of life. It's a really serious and important thing. What do we want to happen at the end of our lives? And many of the debates about this are around avoiding resuscitation or committing to resuscitation. But there are many other things, many other forms of treatment that might matter then. This was very exciting for me. It was a piece of work that gave me the opportunity to actually be involved in changing practice. And I was pretty happy about this until I suddenly found myself very ill in hospital and on the end of a treatment escalation, the wrong end, to tell you, of a treatment escalation plan. And then I started to think a lot more seriously about it. But like everything that I'm talking about today, the civility and dependability of a plan is a system property, not a personality trait. And by that I mean that it is a systemic intervention, not a matter of personal choice. And that it demands particular behaviours and outcomes that go beyond good communication skills or making time to do things. It's actually about the production of accountability, the institution of accountability. So the second of these principles is that we should do things that promote clarity of purpose, ease of navigation, and continuity of care. Now, I know this sounds like motherhood and apple pie, but actually it's often not achieved. Even in very well-funded healthcare systems that are not short-staffed, it's often not achieved. And I'm very fortunate to be working with colleagues at UCL, Professor Alison Roger and Fiona Byrne, on a trial of health and wellbeing coaching for people living with HIV. Now, there are multiple minoritized or marginalized populations in that kind of epidemiological family. So many Black African women, people who have been caught up in infected blood scandals, as well as drug users and gay men and women. So our intervention is intended to deal with the problem of fragmented services and role confusion and the way that those shift burdens onto people who may well be least able to deal with them. So across all of the members of the epidemiological family that I'm talking about, there is a high prevalence of mental health problems. Those problems actually intervene to shape the way that those people encounter services, and they are framed through multiple forms of traumatization and stigmatization. And I found doing this work completely Karen, you need to mute. Assuming it is Karen, I might have just accused somebody who's completely innocent. So if I have Karen, I'm sorry. Anyway, look, and the final of these principles, I'm going to hide over here for a while now. The final one of these principles is the importance of workload reduction. And in 2009, before some of you were born and wild dinosaurs walked the earth, Francis Mayer and Victor Montori and I wrote a paper called "We Need Minimally Disruptive Medicine." A paper that I really like. I wrote it, the main body of it, on Christmas Day in 2008 because everybody else in my house had flu and I was sitting there with a bottle of wine that nobody wanted. I banged out 2,000 words or so and sent it out. Francis and Victor brought it up to speed and made it into a proper paper. But one of the things that I observed on the basis of earlier work on the implementation of telemedicine systems, which has been a long-standing interest, was that many problems that ordinary people experience in healthcare are in fact structurally induced, and that they lead to structurally induced non-adherence. And originally in the paper we called it structurally induced non-compliance, because that meant that we could have a heart sync system as well as heart sync patients. Now, many of you are too young to know about heart sync patients, but in the 1980s and 90s, there was a lot of writing in general practice about that patient who comes into the room and your heart sinks. I may be that patient, incidentally, so my problems are structurally induced. They're not personality traits, as you can see. So there's a whole load of stuff that's going on here. But workload, the more work you put on patients, the more work you put in families, the less likely they are to achieve it. And this is because very few people can afford to be full-time patients. They do actually have other things to do. You know, like they have to earn a living, they have to clean their houses, they have to look after their relatives, they have to watch Strictly. That's a key part of social life now, I'm told. I've never watched it. I'm too posh to watch that. The whole business of workload management and workload reduction is actually crucial to being an effective patient. If you're overburdened, you cannot do what you've been asked to do. Now, these are general problems, but they are experienced very particularly by some groups. So during the pandemic, who remembers the pandemic here? Yes, because systemically it's now been forgotten. I had a wonderful PhD student, Ada Humphrey, who did a fabulous ethnography of how marginalised and minoritised people were engaging with digitally mediated primary care. And how this was very difficult for them if, for example, they didn't have a private space that they could use to talk to doctors, or if they didn't have unlimited data on their mobile phones, or perhaps if they didn't have a mobile phone. So we had patients who were having to borrow phones, go and find a phone box in the street to use that mobile phone privately, or to discuss their various health problems in a shared house or a home, what's now called a home for multiple occupation, where they might be living in one room with their partner and children, or just with their children, sometimes with their parents. So these are very poor people who are ill-equipped to live in a digital world. Many of these people were also members of migrant groups, and they didn't necessarily have good English. And it's really difficult to engage with a doctor. One of them, I think in the study, one of her participants talked about having a consultation with a doctor who was clearly in her kitchen feeding her children breakfast while that telephone conversation was going on. And they experienced very profoundly the kinds of inequalities when somebody's dealing with Tabitha and Jacinta's failure to find their whatever it was they needed for their homeschooling. So these things brought home to people who didn't previously need to think much about it, because they could actually go and negotiate in person with a GP receptionist. That's now very difficult to do in England. I can't speak for Scotland, but it's very difficult to do in many English general practices. So look, here we are. What can we do about it? Well, one of the things we can do about it is ask these questions about any intervention and any service redesign. These are very simple questions. But the other thing we can do is we can start doing equity audits. So in the paper that I can't show you because it's not been published yet, thank you, BMC, we actually set out questions that could frame an equity audit. Now, I'm a theoretical sociologist most of the time, so doing anything that has a practical consequence comes as quite an alarming experience to me. But I really like this idea that the kind of work that we do might actually inspire genuinely critical questions about responding to real social and political problems. So, content for an appraisal tool. Well, one of the things that we might want to ask are these questions. I like these questions because they apply to everyone. They can be applied to everyone. And if we apply them to everyone, then we're beginning to ask the question, the really serious question, I think, is who needs to be exceptional to use this service? Many people need actually to have exceptional skills and talents to manage their engagement with the healthcare system. This is true, I think, across the industrialized world. When I talked about this earlier in the year in Canada, a group of people who were doing research with Indigenous Canadians, First Nations Canadians, pointed to how exceptional people needed to be to move from rural, incredible poverty into a high-tech, industrialized, highly funded healthcare system. It requires exceptional skills for those people. I also think that one of the critical questions we can ask is, what sorts of problems are interventions and service redesigns intended to actually address? And are they intended to think about inequity and resolving those problems? And I had a quick, I'm not doing a system review of this because I don't have time, and also I have a life. But I looked through a whole load of published protocols of large complex intervention trials. I simply looked for the word equity or inequality or whatever. And in almost none of them was there any conception that patients might not be middle-class white people from Surrey, which is where I'm from, so I draw on it, but you can find your own location to ask that question. And I was hugely disappointed. Then I also began to think about the work that I was doing with Elvin and Corey and Alice Hillis about integrating critical race theory and implementation research. And I began to ask the question, well, the critical race theory, which is, where is the restitution? Where is the restitution in interventions and changes? If we go to Alabama, we can easily see where the opposite of restitution is being enacted. Is anybody here from Alabama? I just realised I'm involved in an incident after the talk, if there is. But the opposite of restitution is everywhere. So the question is, where is restitution in the work that we do? And who do we hold accountable for the propagation of interventions, of inequities in interventions and service designs? Who's accountable for that? Because we have systems of research and we have systems of healthcare organisation and delivery that are distributed. They're distributed cooperative networks. There you go. So, our work on burden of treatment theory kind of predicts that interventions that improve patient experience are those that acknowledge and attack dysfunctional, systemic, and relational aspects of healthcare. I throw this in because I've recently seen a paper that suggests that I've made some predictions. I kind of feel that perhaps I have inadvertently done exactly that. So, to conclude, implementation is never neutral. Never neutral. It always involves assumptions about eligibility, about strata, about functionality and resource management. But if we treat equity as part of the design discipline, we can start to think about how to deal with this. And we can start to think the audit lenses that we might use to examine this. And as I've just said, the decisive technical test for any intervention is who must be exceptional for this to work. Who are the highly skilled people that these interventions are sometimes designed for? And so if we design to remove exceptionalism and restore standing voice and recourse as routine properties of care, then we might make some achievement. So finally, the whole aim of my work over many years, I think, has been to provide a rational framework for implementation action. And here I'm trying to provide a rational framework for including equity in those activities. Okay, so thank you very much.
So thank you very much for that very thought-provoking talk. I'll open the floor to questions from online or from the room.
Yeah, I work in mental health research. So you can get, I'm thinking about like young adults who find it difficult to navigate this.
I must tell everybody, I've reached that point in the male life cycle where vanity and impairment are in perfect balance. So can I just ask you to speak up because I haven't got my hearing aid.
I'm sorry. I work in mental health research.
Yeah.
So I'm thinking about young adults who might find it difficult to navigate these systems, also people with socio-emotional difficulties.
Yeah.
And also you hear about, for example, as well, people with drug-free treatment orders who end up with difficult interactions with services. And I'm wondering what you think individual mental health staff, for example, or nursing staff could do to challenge this inequity, and if they also need to be acceptable to do so.
Well, everybody can challenge it. Everybody can make a point. And if enough people make points, then that provides an impetus for change. You know, a long time ago, well, when I started as a medical sociologist, there was a very paternal medicine. And that had disappeared in many medical many medical specialisms and many services. But sometimes it's been replaced with a kind of, well, you know, sort of monitoring. And I don't mean to disparage people who are often working in hugely difficult and constrained circumstances. Absolutely miserable circumstances sometimes, and who are pretty much heroic in turning up to work. So I'm not suggesting that they are in some way deficient. What I am saying is that when everybody does something, then it's very difficult to and more digital healthcare probably isn't the answer. More portables aren't the answer. Unless you have unlimited data on your phone. I just got my class.
Okay. Any other questions, Alistair? Linda?
Yeah, thanks very much. One of the things I was wondering about is the more macro level systemic influences on health inequalities. So not health services, which might be the meso level, the individual micro level. But the NHS, which provides most of the health services in the UK, is so politicised. You've got one side who are looking to reduce services. So, for example, migrants would not be entitled to services. You have mainstream parties who are both trying to push private healthcare usage. So you'd end up with the mainstream health services that's dealing with a smaller block in the middle and suffering as a result. How do you overcome these kinds of inequities? Easy question.
I did have some pictures of Lenin, but I need to take very seriously. That requires a political consensus that doesn't exist. It requires a social consensus that doesn't exist. That exists probably less than at any time it has in the past 50 years. This is why I focus on intervention and service design, because those are things that can be changed. The economic structure, the social and economic structure of the United Kingdom has proved itself recalcitrant to major change in the direction that I think you and I might like it to go. In fact, it's proved itself very supportive of exactly the opposite of those changes. So focusing on intervention and service design, I think, is the way forward, because that is changeable. Those are changeable. But the steady kind of erosion of the notion that citizens have a right to care is, I think, one of the very sad features of the political environment.
Okay, I'm going to hand over to Derek the next question, and I'm going to hand over chairing to Kate and say, I don't want to stop all the questions. I'm thankful very much, and I will speak to you later, but I have to rush out elsewhere. But thank you very much. Hand over.
Well, this is not to defeat capitalism.
Carl, I had a very interesting new equity audit tool once it gets published by BMC. Just to introduce myself, I'm Derek Connolly. I'm a cardiologist. I've known Carl for more than 30 years, and I'm interested in treating patients and investigating patients with heart rhythm problems. Now, these days, if we see someone with symptoms and we need to get a recording of their rhythm, we can do one of two things. We can put them on an NHS waiting list for about 6 to 12 months for them to get a recording device that they carry with them, or the patient can go out and buy a smartwatch so they can make their own recordings. And if they are wealthy enough to spend a few £100s on that, they'll also want my email address so that they can send me multiple recordings every day, and they'll expect an answer straight away. It's a perfect example of inequity that we really like to look at. And my problem is, how do I get the technology out to the poorer parts of our city and not have medical technologies exacerbating these inequities?
I think that's a fantastic question, Derek. I think, well, first of all, good luck to anybody who tries to get a consultant's email address. You know, if you could do that, you are one of the exceptional patients that I was speaking of. But to be very serious about this, well, I know that there are important questions about the accuracy of these devices, these tools. And I can't speak to that, although I do know that there are some pretty shoddy pieces of tech on the market that claim to do this. more or less, if it's under 200 quid, it's a pretty shoddy piece of work that won't do the work, won't do the job. But there would be actually nothing to stop a health authority of any kind buying some of these tools and having them used in GP practices where you can pretty much pitch up at a GP practice in my part of the world, and they'll do most of these sorts of things. I mean, my GP practice has an EEG machine, and somebody can use it. I think that person is now at risk of being struck off for other reasons, but I won't pursue that. These technologies are available and they are distributable, but it requires a slightly different view of purchasing and procurement. And one of the big lessons of all of the work that my group has done since 1995 on telemedicine systems and remote monitoring suggests to me that it is very difficult for tech manufacturers to find people who could actually buy these pieces of kit. It's incredibly difficult to find in a health authority or a trust the person who would actually procure them. So that's a systemic problem. And it's a result, it's not an insuperable one. I mean, when people want to do something, they can normally do it. But the issue there, I think, would always be about whether these pieces of tech actually do the job that they promise to do. I think there's some good work now that says that they didn't. But simpler tech, like O2 monitors you put on your finger. I mean, during the pandemic, I had one of those. Lots of people had them. You know, somebody was making a fortune selling those. Hi, Michelle. And she's just bought a £10 million house in Miami, incidentally. Possibly on the basis of my purchase. So,
Could take an online question and then hopefully time to come to David. So Rijika has asked about global inequity. How does that influence implementation science? And cites global disability in relation to mental health reduced since the 1990s.
That's very true. Well, there are some issues here about there are some issues here about what individual states will pay for. And an important feature, I do work in East Africa and West Africa and now also in Argentina. And many of those states are hugely depleted in terms of what they can afford, in part because of the predatory behaviour of organisations like the International Monetary Fund and the shift from publicly funded donations to those countries to private loans. And it must be said also now, state-sponsored banks from China who are extracting capital from many of those countries on a scale not seen since the Brits were there in the 19th century. So there's some really interesting features of this. I think one of the things about this is that if you look at how donor countries respond to these problems, and how the WHO respond to the existence of these problems, they are big on conceptualizing inequity that are averse to pushing political programs that will achieve it. And those are left to the Gates Foundation, those kinds of mega donors, or individual donor countries. So there is a peculiar health economy in some of those countries that is about the relationship between healthcare services and clinicians, and the clinicians are often absolutely outstanding. So I'm involved in some work about implementing a new regimen for TB care in 2 East African countries, and the clinicians that we deal with are just outstanding and significantly underpaid and significantly undersupported. And so we are relying on effectively a pharmaceutical company donating those drugs for the duration of our study, which will last for 5 years. So we'll have a big hit, and it's not a trial, so everybody who uses those clinics will get it. Mental health is always the poor relation. It's the poor relation everywhere. It's not sexy, it's not exciting, it's often not curable, it requires complex and intensive management. Our model of hierarchical inequity that I presented earlier actually included schizophrenia, psychosis, and bipolar disorder. Huge common features of the workload with other non-psychiatric conditions. So it was very difficult to tell apart analytically the accounts of people with episodic inflammatory bowel disease and the accounts of people with episodic bipolar disorder, except in their description of symptoms. But so much else of what they said was common. It was quite extraordinary, and I was expecting there to be major differences, but there weren't. I answered that question satisfactorily.
Yes, there's teaching coming in 20 minutes or so. So we've got another time for another question. There might be someone in the audience.
Thanks, Carl. Lots of food for thought. I guess a couple of things up your comment about redesign, maybe think about university design for learning from the sort of educational technology space. But one of the things that I think could be challenging in the health services context is the adverse care law and the fact that we know that you're going to need more resources in more disadvantaged areas to deliver on any of this. So the first question is there a kind of buy-in for proportionate universalism in the audiences that you've discussed this work with? And the second question is, how does this relate to a broader literature around structural competency within healthcare professions that's been going around for a while?
Well, thanks for that life's work, David. I think, first of all, there is an inverse care law that exists across the whole arena of public service, and it's just as pressing in education or social care or social work or most public services, I think. I think there is not universal support for the kinds of ideas that I propose in this presentation, and that's for 2 reasons. The first is that the idea of doing equity audits is a really risky one for organisations. If you start saying, well, we want to do an equity audit of a service, or if you're a big complex trialist and you say, I want to do an equity audit of my trial, then the chances are you're going to discover something that you didn't want to know. Okay. I feel so there isn't universal support. There's universal moral support for proposals like this, I think, because I'm kind of proposing a good thing. It is good, and it's a warm and fuzzy good. But in practice, these things will be very difficult to do, and they will be very difficult to translate into change. Because to translate them into change requires a sort of a body of systemic work that means that people have to rework themselves, they have to rework their services, and they probably have to recost their services. One of the reasons that health and wellbeing coaching for people with HIV, I think, is a good thing, is that in fact it's a way of gluing together fragmented services and doing the navigation that isn't available. I mean, I would like to see that for people with inflammatory bowel disease or diabetes, and there are some pretty good coaching programs for diabetes, but they tend to be governed by individualistic theories of behaviour change. It's difficult, to my mind, to promote individual behaviour change in a social context where individual behaviour is shaped by massive structural forces. There's a really great paper out today about public health interventions as complex adaptive systems. Really nice by a group of, I think, Dutch authors that I was reading on a plane coming up. Kind of thinking about those imponderables that get incorporated, those complex systems that become incorporated over time in the sorts of things that I'm talking about. Yeah, it's really, really difficult. That's one of the reasons that I've tried to focus over the past, I don't know, 1,000 years, it feels like, on mechanisms that are about adaptation rather than complexity. So the variables that we've defined in normalization process theory or burden of treatment theory are largely adaptive. And they damp down complexity when we look at them rather than add to it.
Okay.
David, I don't know whether I've satisfactorily answered your question, but I hope so. Thank you.
I think we could probably keep this Q&A and discussion going all afternoon, but we have other calls in the room, and also in terms of your own time, Carl, I think all I want to do is again reiterate Frances's thanks for, as always, really fascinating, thought-provoking talk. I guess if people want to have a chat with you, you'll be about for a little bit to do that.
Probably will.
But we could just all thank Carl again for his time today.